Today I thought I'd talk about multimodality cardiac imaging, highlighting the multimodality aspect with interesting and challenging cases. And the reason why I've decided to talk about a very clinically based topic is because some of you, maybe a lot of you, don't do cardiac imaging, so it's very hard to discuss cutting edge techniques when it might be hard to apply to your own practice, and especially if it's not your own specialty. My objective is quite simple. So I'm sure most of the visiting professors you see have multiple objectives for their talks. I really only have one, to keep it simple. And my objective is just to highlight the strengths and limitations of cardiac echo, CT and MRI using some interesting and challenging cases. And the reason why I do this is really a matter of cognitive load theory. I've noticed as a teacher, when I try and teach a complex topic to a group of medical students or residents or fellows, if I try and do too much in a short amount of time, it's lost on them. So this cognitive load theory is something I find very interesting. So if you read on cognitive load, you might come across some work done by Dr. Miller in the 1950s based on magical number 7 plus or minus 2. And what that means is the human working memory can only process 7 pieces of information at any one time. And it kind of makes sense when you think about a telephone number. It has 7 digits, right? Excluding the area code. So it kind of makes sense, like you can deal with a small amount of information at any one time. Now, some people have refuted that and said, well, the magical number is actually not 7, it's more like 3 plus or minus 2. So depending on what you read. So this cognitive load theory is how I try and devise my talks to try and minimize the amount of information that I'm going to talk about. And so this is the minimization of this extraneous load, which can be distractors in your presentation, and trying to manage the intrinsic load. So the intrinsic load is basically the complexity of information inherent to what you're trying to teach. And you can manage that by breaking the information down in meaningful packets of information. Germane load is the ability for you to focus the audience on the task at hand and to give them skills so that they can create their own schemas or algorithms to understand your information. So you want to maximize that. Ultimately, I want to avoid overloading you with a lot of information, otherwise this will happen. Can anyone understand this message? Well, how about here? So this is what I mean about packaging information in a way that is meaningful and easy to understand. And I always think about this when I'm trying to teach residents, right? I'm sure, Ali, you deal with teaching residents all the time. It helps to think about how we teach and how to break it down into facts or algorithms, approaches, so that it's easily understandable by the resident or trainee, and also so that you can teach them the skills so that they have an approach for life. So I use this example. How many of you watch Game of Thrones? Anybody here into that? Yeah, I hear it's a great show. I've bought the Blu-ray discs and I haven't had a chance to read or watch it yet, but I will. So multimodality cardiac imaging, in a way, is similar to the different kingdoms in Game of Thrones, but it's also a little bit different. So instead of thinking of all these modalities as competing against one another to be like the best modality, they're more like pieces of the puzzle. So multimodality imaging for cardiac imaging is sort of a way of life for me. All of these tests provide very useful information, but they're like pieces of a puzzle that fit together. So there isn't one modality that's like the one-stop shop or the best modality for cardiac imaging. It's sort of like we work together. Whoa. I love that theme. I think this is the reason why I'm going to watch this show. But anyway, it's an example that I use to highlight why multimodality imaging isn't really a competition. It's pieces of the puzzle. Okay, so without further ado, our first case, unusual case of acute back pain. So this was a 59-year-old woman, physically fit. She had a high-profile job. She was admitted to the CCU very recently based on her outpatient echo and her exertional symptoms. Her past medical history, relevant for a bicuspid aortic valve. She had a bioprosthetic valve inserted in Toronto and then moved to Mexico. And while there, she had a torn aortic cusp, and it was repaired, replaced the bioprosthetic with a mechanical St. Jude valve, and then she was anticoagulated. 2007, she moved back to Toronto, was followed at the Toronto General Adult Congenital Heart Disease Clinic, and then was also seen in thrombosis clinic. In December 2013, she had an episode of right eye visual loss, thought to be a TIA. In terms of her history of present illness, she was relatively well for 3 weeks, had this recurrent back pain relieved by rest, and now she was intermittently having pain at rest. No previous injury, no previous back pain, no radiation of the pain, no constitutional symptoms, no fever, no syncope or palpitations. So her blood work revealed only a mild elevation in her C-reactive protein, and her highly sensitive troponin T was elevated, although I should mention this was obtained after her first imaging, which was a stress echo. Her INR was elevated, but no fever, as I said, and no elevation of her white cell count, and her CBC was otherwise normal. Okay, I'll just use my mouse here. So this is the rest exercise echo, and this is the stress after treadmill. And you can see that with stress, there is abnormal wall motion in the basal to mid anteroseptal wall. It's hypokinetic after exercise. And she had a very markedly positive ECG showing ST depressions in the precordial leads as well as lead 2 and 3. And also on this stress echo, we see this finding, kind of unexpected, but it was a mass on the mechanical aortic valve, thought to be a vegetation or thrombus. And so because of that mass, she was further evaluated with the TEE, and when you see that here, the Doppler images only shows a very minimal vascularity. And then here are some 3D pictures. The arrow is showing the mass on the mechanical valve, and here's a 3D picture showing on the LV outflow tract side of the valve, this little mass. So because of it, there was hesitation to perform a diagnostic catheter angiogram to evaluate the coronary arteries because of the risk of embolization during the diagnostic cath. So they ordered a coronary CTA instead, which I thought was very reasonable. So this patient now was being worked up for possible angina, although she presented with back pain because it was related to exertional, it was felt to be exertional in nature. It was postulated that her back pain was actually angina or an angina equivalent. So the CT shows some soft tissue density that was there back in April, and that previous CT was performed for just routine follow-up of the mild dilatation of the aorta. What we see in addition, highlighted in blue, is that there is more soft tissue density and now encasing the proximal left anterior descending coronary artery. The image on the left, it looks like there's some narrowing of the coronaries, but they were actually normal. That's just volume averaging. So on this CT that we performed, we did an arterial phase as well as delayed phase, and we noticed that on the delayed phase, there was actually enhancement. So initially we thought, because of her elevated INR, could she have had a hematoma that developed, like a spontaneous bleed that caused the coronary artery compression? But the fact that there was contrast enhancement within this mass at 3 minutes confused us a little bit for hematoma, and it basically said to us, this can't be just a simple hematoma. And with the volume rendering, I contoured out the mass just to show the extent of it and how big it was. So multiplanar as well as curved planar reconstructions show that there is total or subtotal occlusion of the left anterior descending coronary artery, as well as the mass that was seen on TEE, as well as the stress echo. So our differential diagnosis at that point was, could this possibly be some sort of abscess or phlegmon because of this vegetation or thrombus that we saw on the aortic root? They often go together. Or could this be an inflammatory mass unrelated and due to some sort of vasculitis? Could it be neoplastic, such as lymphoma or sarcoma? And could this be something else, like a vascular malformation? We felt unlikely, given the fact that it had grown over 6 months. So what would you do next? Maybe think to yourself, do we want to do show of hands, or do you want to just do it privately? Any thoughts? Residents, or Justin?
I think getting a surgical consult is pretty reasonable to get their thoughts.
Absolutely, and that's what we did. So I reported this case as suspicion of chronic phlegmon abscess with a vegetation on the valve. And so we consulted the surgeon, and they took the patient to the OR and found a hole just above the sewing ring of the St. Jude mechanical valve. And that mass that we saw on CT corresponded to a very hard, rubbery, but not a discrete mass at the OR. So it didn't look like a tumor. It was really just fat that was very hard. I heard the surgeon describe it as Indian rubber, which I'm not really sure what that means, but something like very firm. It wasn't something that he could resect. So this hole was likely the cause of the inflammatory mass encasing the proximal LAD. And then I have another image, and the other interesting thing the surgeon told me was he could just plop that valve right out. Like, it was a miracle it didn't dehiss. And the other thing he noticed was that there was an oily film on the St. Jude mechanical valve. And interestingly, these Teflon pledgets are there to prevent leakage around the sutures. Over 8 years, they were never incorporated into a fibrotic ring to stabilize the valve, which is a sign of infection usually. So it's rather interesting that in this patient with no fever, no white count, with negative blood cultures, had findings at the OR very suspicious for chronic prostatic valve endocarditis. So how often does that happen when you have endocarditis with negative blood cultures? Well, this review reported about 5% of cases out of their 122. However, they postulated that those negative blood cultures were probably due to the fact that the patient was started on antibiotics. But in our case, the patient wasn't started on antibiotics, so it was a little bit unusual. So I only show it because, you know, I had gone down the tumor path with this case because of the enhancement, but once I saw that little vegetation or thrombus on the aortic valve, it made me think, well, what's most common? It's really rare to see a thrombus or vegetation on a prostatic valve outside of the setting of endocarditis. Okay? So that was an interesting case. So those are the teaching points. Even though it's unusual to have prostatic valve endocarditis with negative blood cultures, it is possible. And so my theory is that when she had this valve replaced in Mexico, there must have been an infection that happened shortly afterwards, and it created this little hole in the aortic root, and there was slow leak of blood out, and then she had tried to contain it, I guess her body was trying to contain it, by mounting an inflammatory reaction, and that's why we see enhancement on the CT as well as encasement of the proximal LAD. And it also corresponds with no discrete mass seen at surgery. And also to keep in mind that on CT and MRI, not everything that enhances is actually a tumor. Okay, so that was our first case. Our second case was also very interesting and took me a while to figure out. So this is a 53-year-old guy, infected pacemaker, pocket, now has a sternal wound infection. So it turns out that this guy, you can see the packing material here. Is there a laser pointer I can use? Somehow does anyone have a laser pointer? Okay. At any rate, you can see in the left anterior chest wall, there's some packing material. So that's where he had the infection of the pacemaker pocket. And he was basically picking at this pocket of pus and transferring it to a scab he had on his sternum. And so he had basically transferred the infection from his left chest wall to his sternum. He has a history of congenital heart disease, complete transposition of the great arteries with an RV to PA conduit, known as a Rastelli procedure. This is his past medical history, which is quite complex and very typical of the patients we see at Toronto General. The only important thing you need to know is that he had an RV to PA conduit. So we performed a CT for query osteomyelitis, and this is what it showed. It showed a sternal wound, an abscess collection around the sternum, as well as findings consistent with osteomyelitis. And the axial CT, just to show you that there were other findings within the lungs, a left-sided SVC, and you can see the calcified conduit there just anterior to the sternum. Here are some lung findings. He had pulmonary findings consistent with sarcoidosis, as well as a cavity and what looked like a fungus ball. So about 4 or 5 days after that CT, we were informed that the patient has a pulsating anterior chest wall mass, and we were asked to perform a chest ultrasound. And this revealed a hypoechoic mass and flow apparently, this is how it was reported, flow apparently connecting the RVPA conduit with the sternal collection. And so the cardiologist asked us, should we drain this collection? Because it looks like some flow is going into it. What would you do? Shall I read this out, or? Okay. C is very, very good choice, Roya. Good call. So that's what we did. Just to be sure nothing had changed since the last CT, we repeated the CTA just to make sure there was no communication that we could demonstrate from the RV to PA conduit to that sternal abscess. So the repeat CTA was pretty much identical to what you just saw. There was no contrast connection, no morphologic connection from the RV to PA conduit to the sternal abscess. And the sternal collection was drained, and it drained frank pus under ultrasound guidance, and the patient did okay. So why was that? Why did the ultrasound show that there was flow communication? Well, in retrospect, there actually wasn't. So the fact that the sternum had a hole in it and a collection of pus allowed the pulsation of the heart to just transmit the pus back and forth through that sternal defect, if that makes sense. So what they were seeing on the ultrasound of the chest, because of their limited field of view, was just the pus going back and forth, not actually blood flow from the conduit. And this highlights some of the limitations of echo and chest ultrasound in that your field of view is often limited, so you don't know what's going on around it, and you can sometimes misinterpret the findings. Okay. So this is another case that highlighted some strengths and limitations of multimodality cardiac imaging. So this was a 56-year-old man, history of alcohol abuse, also use of marijuana, and he has a 1-week history of increased shortness of breath on exertion with orthopnea and paroxysmal nocturnal dyspnea. No chest pain or palpitations. ECG showed sinus tachycardia as well as left ventricular hypertrophy and premature ventricular contractions. Now, blood work revealed a very elevated brain natriuretic peptide level, so this is a marker of heart failure. So it was clearly abnormal. Catheter angiography was normal. His troponin level was only mildly elevated. And this is what the echo showed. So the top left image is an apical 4 chamber, and this echogenic mass was questioned to be a thrombus. And you can see on the sweep that it's hard to tell, is it thrombus versus just very hypertrabeculated, spongy myocardium. And I also direct your attention to some very low echogenicity material, which you'll actually see better here. For example, this area. So contrast was given, and in our echo lab we used DEFINITY contrast. And you can see that his function was clearly abnormal, that the contrast agent wasn't even being squeezed out of those trabecular recesses because his cardiac systolic function was so poor. And if you pay attention to this image down here, you can see the contrast actually gets taken up within the myocardium, and then there are some areas that remain hypoechoic. Just pay attention to where the mouse marker is. Right there, where the mouse is. So I'll show you what that corresponds to. So this was reported as query diagnosis and possible thrombus at the left ventricular apex. Here's another 4-chamber view. Again, some areas that never take up the contrast agent. Normal myocardium should take up those little microbubbles. Areas of infarct, infiltration with some other process, or thrombi do not take up the contrast. Okay, so you can see areas that remain hypoechoic. His ejection fraction was very reduced at, I think they calculated 15% by the biplane Simpson method on echo. So here's the MRI. So those areas I was pointing out correspond to thrombi, but there were many more thrombi detected on MRI. And this sort of highlights the strength of MRI compared to echo, even with DEFINITY contrast. You can always detect more thrombi with CT and MRI compared to echo. So in addition to these thrombi, we also see areas of enhancement. I'm not sure what happened to my mouse, but you can imagine at the apex, just around here, there's some bright areas of the subendocardium that take up the contrast as well. So this is very characteristic of a particular diagnosis. Does anyone know? Yes, excellent. This is non-compaction cardiomyopathy. So the other options here, I'll kind of go over. Apical hypertrophic cardiomyopathy is a form of hypertrophic cardiomyopathy where the apex is abnormally thickened. You can get apical aneurysm as well as thrombus formation, and usually when you have mid-cavity obstruction. And the pathophysiology is such that when you have mid-cavity obstruction because of thickened muscle, the apex has to squeeze harder to bypass that mid-cavity obstruction, and there's a supply-demand mismatch in terms of blood flow, and so the apex infarcts and forms an aneurysm in apical HCM. With Takotsubo cardiomyopathy, it's due to catecholamine surge, and because we have more beta-2 receptors at the mid to apical level of our hearts, that's the area that is dysfunctional. But this is considered reversible, and typically there's no associated late gadolinium enhancement. And with dilated cardiomyopathy, it's kind of nonspecific. You have a dilated left ventricle. You might see mid-wall late gadolinium enhancement. Here on this still image of the steady-state free precession, we see some chemical shift artifact from some fat that had infiltrated an area of scarring. And the right ventricle is enlarged in this case of dilated cardiomyopathy as well. And with non-compaction, what we look for is a very spongy, hypertrabeculated layer of myocardium with a two-layer appearance, meaning that the subendocardium creates a connecting meshwork as well as the compacted layer. And typically the compacted layer is abnormally thinned. But non-compaction remains a diagnosis that can be controversial because of varying criteria in the literature. So it's caused because of arrested development of the normal formation of compacted myocardia. And this happens in the 5th to 8th weeks of life. Compaction starts at the base and moves towards the apex, and it starts in the outer layers of the heart and moves its way in. And that's why we see non-compaction most commonly at the apex and involving the subendocardium. So one of the hallmarks is to see these deep trabeculations in the myocardium, typically mid to apical level. It can be associated with heart failure, TIAs, and stroke, and also thrombus and arrhythmia. Now, isolated left ventricular non-compaction is relatively rare. Most commonly, we see hypertrabeculation that looks like non-compaction secondary to other conditions, such as congenital heart disease, neuromuscular disorders, and so forth. And the diagnosis is controversial also because there's no good gold standard for diagnosis, no good lab test or genetic test. By MRI, we usually use an end-diastolic measurement of 2.3 to 1, measuring the non-compacted to the compacted layer. We look for that two-layer appearance and for a thinned compacted layer. On echo, the measurements are completed during end systole, and they look for a 2 to 1 ratio. Using contrast agents can help. So the teaching points here, we call this non-compaction cardiomyopathy, but it's sometimes hard to distinguish hypertrabeculation secondary phenomenon to dilated cardiomyopathy versus true isolated left ventricular non-compaction. Ali, what would you call that case? Would you call it non-compaction, or would you call it dilated cardiomyopathy with secondary hypertrabeculation? Yeah, I think so too. I think the degree of hypertrabeculation was a little bit too much for a secondary hypertrabeculation as a compensatory mechanism. Okay. How are we doing for time, by the way? Okay. All right, so this is great. This is a very interesting case. And interestingly, every single case I'm showing you was done in the last month. So it shows you the scope of cases we do at Toronto General, and that I can easily find cases to show. Okay, so this case is very interesting too. A 63-year-old man with new biventricular heart failure. His New York Heart Association classification was a grade 4 ventricle with an EF reported on echo of less than 20%. And he had a catheter angiogram which showed significant triple vessel disease, also a history of alcohol abuse. so these are still images from his catheter angiogram, which shows 80% LED lesion. Now this is one modality I don't do, so I just report what the cardiologist reports. This was called an 80% lesion at the first obtuse marginal branch, and also very high-grade proximal and distal stenoses in the right coronary artery. The distal right coronary artery was reported as being occluded. So the clinical question here is, the patient has 3-vessel disease, but also has a history of alcohol abuse, has clear left ventricular systolic dysfunction. Would doing a CABG restore left ventricular function? So the cardiologists were considering, should they do a viability cardiac MRI? So this protocol in our toolbox allows us to understand how much is infarcted myocardium in the setting of ischemic heart disease versus how much is viable. So the viable myocardium is the non-infarcted but still dysfunctional myocardium, and it's often what we call chronic hibernating myocardium. So it's ischemic, there's wall motion abnormality, but not yet infarcted. And it would be expected to improve function after revascularization with CABG. So a stress perfusion MRI provides additional information. What it tells us is the area of reduced perfusion, in other words, ischemic myocardium, not due to infarct, because an infarct can actually have areas of reduced perfusion within the area of infarct. But doing a stress perfusion MRI with either dipyridamole or adenosine, we don't use dobutamine, but some centers do, tell us what are the areas that are ischemic due to the coronary artery disease, not yet infarcted. So the difference between viability and stress perfusion MRI is the stress perfusion MRI provides you additional information of ischemia. Like there are areas that are clearly reduced in blood flow due to the coronary artery stenoses. Whereas the viability just tells you what's the function and how much is infarcted, and you kind of infer that the non-infarcted myocardium is still viable. So stress perfusion MRI is great because it assesses multiple levels of the ischemic cascade. We assess the perfusion defect by giving adenosine or dipyridamole and then imaging the patient with stress perfusion images. And then we can assess regional wall motion as well as global systolic function, calculate the ejection fraction, and then we look for irreversible damage in the form of late gadolinium enhancement due to the infarct. So the perfusion principle, as many of you know, is based on the fact that ischemic myocardium has less blood flow, slower peak, slow time to peak, decreased peak, and then slow washout. And so what is the sensitivity and specificity of MRI? I just wanted to bring this up because I think stress perfusion MRI is underutilized in general in Canada. So it ranges, but based on this meta-analysis, sensitivity and specificity are in the high 80s for sensitivity and specificity around 80%. So this is an important study called the CE Mark study, which looked at over 600 patients who all received stress perfusion MRI, SPECT, as well as coronary angiography. Most of the patients were white males, average age 60. And I just show this to highlight the fact that we know that stress perfusion MRI performs better than nuclear medicine with SPECT. But despite that, I think there are multiple factors that contribute to underutilization. One of the important factors is probably accessibility, but we're trying to build a stress perfusion MRI program at our center, and we've noticed that there's a bit of a conflict of interest because a lot of the cardiologists are reluctant to refer to a modality that they don't bill for, and that's why nuclear medicine still is used quite often at our center. But it actually performs better than nukes with SPECT. So back to our case. So we have perfusion, stress perfusion MRI, but no perfusion defects seen at stress or rest, as you can see here. And the late gadolinium enhancement images show biventricular dilatation and this mid-wall enhancement that's quite typical of non-ischemic dilated cardiomyopathy. There's no late gadolinium enhancement elsewhere. So just to contrast a non-ischemic pattern with an ischemic pattern, an ischemic pattern we would look for subendocardial moving towards transmural late gadolinium enhancement confined to a vascular territory. And this is an example I showed the residents of an LAD chronic infarct with thrombus. So the difference being this infarct is transmural, whereas this non-ischemic pattern is just involving the mid-wall of the myocardium. So we didn't see a lot of late gadolinium enhancement, just a little bit of mid-wall in the septum. Does this mean the entire myocardium is viable? Well, technically speaking, the absence of late gadolinium enhancement is consistent with viability, but there were two issues that complicated the interpretation of this case. Number one, the patient had a blunted response to the dipyridamole, meaning his heart rate didn't really change and we expect it to go up. His blood pressure didn't change and he remained completely asymptomatic during the dipyridamole injection. So I was wondering, did he somehow have a blunted response to dipyridamole, and does that reduce our sensitivity to detect ischemia? In addition, he had that mid-wall enhancement that I showed, and could he actually have cardiomyopathy due to his alcohol use rather than chronic hibernating myocardium? What do you think, Ali? How would you report that?
And you may have a bit of both.
It could be both, exactly. So at this stage, that's an excellent point. I wasn't sure how much of his biventricular dysfunction was due to alcohol and how much was due to chronic hibernating. With stress perfusion MRI, we weren't able to show areas of ischemia, right? Had we been able to show that, that would have been very helpful. So what do? I suggest another modality. So I said, why don't we do a dobutamine stress echo? Because this is another modality that looks for ischemia. So I figured if we had two tests that failed to show ischemia, then it would bring into question whether doing a CABG would really help improve this person's function. So this is a dobutamine stress echo. These are the rest images. You can see the severe systolic dysfunction. And so what we look for on dobutamine stress echo is what we call a biphasic response. So when you inject more dobutamine, an ischemic area should start to contract better at low dose, but once you start to inject more dobutamine, it starts to contract more poorly. So that's the biphasic response you look for ischemic myocardium. And we didn't really see that. So this is stage 5, the highest dose of dobutamine. And there weren't really areas that did worse. So what we're looking for is improvement at low dose and then worsening function at high dose. We didn't really see that. So with two tests, both stress perfusion MRI and dobutamine stress echo, failing to show convincing ischemia, it was felt that CABG was not really indicated because of the high risk of surgery with questionable benefit. And so we felt also the cardiac dysfunction may be largely due to the alcohol abuse and this non-ischemic dilated cardiomyopathy. But despite this, our cardiologist planned to angioplasty and stent the LAD as an outpatient. And that reflects two things: how aggressive our cardiologists are, and secondly, probably in their defense, to improve long-term outcome, because we know he has severe 3-vessel disease, and this is to prevent that heart attack that kills him down the line, if that makes sense. So it's to prevent, to improve long-term outcomes and to prevent that fatal MI. Okay, so this is a very interesting case that I was involved in as well. So this patient had 2 chest x-rays, developed new left-sided chest pain, and the ICD stopped working. So as soon as you hear that history, it should ring off some alarm bells on what to look for. And although this was not reported at the time on this chest x-ray, I reviewed it before reviewing the echo, and I was a bit worried that the defibrillator lead had moved a little bit further inferiorly on the PA view and perhaps a little more inferior, although it was hard to tell with varying position of the hemidiaphragm. So this case highlights another phenomenon with echo in that it's very operator dependent. So the sonographer came to me and said, well, this is query lead perforation. I really can't see the lead very well. I don't think it's perforated, but I'm not 100% sure. So I said, okay, that's fine. I'll go in and scan the patient. And these are the images that I was able to obtain. And you can see in the bottom right image how this is the edge of the RV myocardium, and the lead is going through it. This is a little bit of pericardial effusion here, this hypoechoic region. And this is another view just showing the lead continuing out the RV and going into the fat adjacent to the heart. And here's just the first view that I obtained. So it highlights the fact that we do need to know how to scan when we're doing cardiac echo, just like ultrasound of the other parts of the body. and how it's very user dependent. And the trick here was that the patient was very large and she had very large breasts. And I used a trick that I learned from a very experienced sonographer in that I asked the patient, I know this sounds bad, but I asked the patient to lift up her own breasts so that I could scan underneath, and then I was able to get really good views rather than struggling in the standard position. So it's very operator dependent. So I reported this as a lead perforation. And sometimes the cases are quite obvious. This is a case that was clearly perforated on CT and CT and plain films, but sometimes it's hard to see the lead tip on CT because there's artifact right at the end of it. So this was a lead perforation, and I will say that echo is the first-line imaging modality to evaluate for possible lead perforation because of its excellent temporal resolution. It doesn't involve radiation. And you get also the information when you're scanning the patient. Like when I was scanning that patient, she complained about pain right where the probe was, so that's very helpful. It's kind of like the sonographic Murphy sign. And CT can be completed where the echo can be equivocal, but it's not always easy because of that artifact that we see at the lead tip. So just to summarize, echo is very non-invasive, it's very accessible, the temporal resolution is great, doesn't involve radiation. The problems are when you have limited acoustic windows. If the patient is post-op and has a lot of bandages or has severe COPD, the echo windows can be really tough. It's also operator dependent, as I shown with that lead perforation case where sometimes you have to scan yourself. And on ultrasound, sometimes artifacts can mimic pathology, and our field of view can sometimes only show us the tip of the iceberg and we don't really see the entire process. And that's particularly true for tumors. With CT, it's also very accessible, great for multiplanar imaging. Spatial resolution is very good. Downsides are that it involves radiation, and when you have a patient with renal dysfunction or allergy to iodinated contrast, it can be difficult to image. And contrary to what a lot of people think, a CT is actually better than MRI, I feel, to show fat and calcification, especially if the amounts of fat and calcification are very small. But having said that, MRI is fantastic in general for tissue characterization. It's considered the gold standard for ventricular size and function. It provides us with viability information in the setting of ischemic heart disease and also involves no radiation. The downsides are, of course, the time it takes to acquire the MRI images, which can be up to 2 hours for a congenital case. There's limited availability in some centers. And we know that it's not a great modality for evaluation of the coronary arteries for coronary artery stenosis because of its limitations in spatial resolution. And I have to say, out of all the modalities, probably MRI does provide the most information in one test, but there are still valuable pieces of information offered by echo and CT. And with that, I thank you for your attention.